Welcome back to the Deep Dive. Today, we are not just opening a textbook.
Yep.
We are really getting into the foundational science and strategy that governs the entire world of cancer management.
It really is the bedrock.
It is. Our source is Chapter 12, The Principles of Oncology, from the monumental 28th edition of Baily and Love.
And this chapter specifically is, I think, the essential bridge. It connects the infinitesimal, the rogue DNA, the mutated genes, all those complex molecular pathways with the macroscopic reality of clinical practice, diagnosis, staging, surgery, all of it.
It's a dense chapter. It's a necessary intellectual lift.
It is.
So let's be absolutely clear on our mission here for you, the listener. This deep dive is our interpretation of that material.
Yes. Think of it as a personalized, high-yield revision roadmap.
Exactly. We're pulling out the critical concepts, the surprising facts, the metaphors that make things click.
The aha moments.
Those are the ones. These are your mental anchors. Now, this is a shortcut to being well-informed, but it is not a replacement.
Absolutely not. Please use this to get that quick, thorough comprehension and then go and crack open the original source.
Right. We want these concepts to stick with you in, the high-pressure environment of a surgical rotation or an exam.
So let's start at the very beginning, the nature of the disease itself. Because the history, it really helps anchor the conceptual shift that had to happen.
Okay, let's unpack that history. The name itself is... Well, it's fascinating. It all starts with Hippocrates.
The father of medicine.
He's the one who coined the term cancer.
Right, from the Greek karkinos, which means a crab.
And that image is just so powerful, isn't it?
It's incredibly enduring. He was describing what he saw, the gross anatomy.
The tumor mass itself?
Yeah, with these hard finger-like projections spreading out into the healthy tissue around it.
It looks exactly like a crab's claws digging into the sand.
It does. It was a perfect descriptive anatomical anchor.
But the big conceptual leap, moving away from just describing what it looked like to understanding the mechanism, that came much, much later.
19th century. Rudolf Virchow.
And his famous dictum.
Omnis cellula e cellula. Every cell from a cell.
Which sounds simple now, but it was revolutionary.
Completely. It established for the first time that cancer was a disease of abnormal cell proliferation.
So not a disease of the blood or some other, humoral imbalance.
Exactly. It fundamentally changed everything. It rooted the study of cancer in the cell cycle, in cell division.
And as soon as we knew it was a disease of cells, the race was on to figure out what was controlling those cells.
And that's where you get the huge 20th century breakthroughs.
Right.
You had Bovary in the early 1900s noticing chromosomal abnormalities, suggesting something was wrong with the genetic material itself. Then Avery in the 40s confirming DNA was that material. But the real key, the discovery that unlocked molecular oncology.
Watson and Crick,
1953. The double helix. Once we understood the blueprint structure, we could finally start to analyze what happens when the blueprint goes wrong.
Which leads us straight to the most critical framework of the last few decades. The hallmarks of cancer.
Popularized by Hanahan and Weinberg.
And this is not just some dense list for you to memorize. Think of it as an operational checklist.
It is. For a cell to go from just a slightly weird clump to a full-blown aggressive malignancy, it has to acquire these specific characteristics.
It's the cancer cell's cheat sheet for taking over.
That's a great way to put it. A cheat sheet for immortality and global conquest. And we can group them by function. So let's start with the two most fundamental ones. Proliferation and survival. Tagged the proliferation and survival hallmark.
Okay, so the first is establishing an autonomous lineage. Essentially ignoring all the traffic signals that govern normal growth.
In a healthy process, like, say, wound healing, cells only divide in response to very specific, externally regulated signals.
And when the job is done, they stop.
They stop. Cancer cells, on the other hand, they just bypass all of those checks and balances.
And their independence comes from the activation of oncogenes.
Right. And what's so fascinating is that most oncogenes are just mutated versions of normal genes called proto-oncogenes.
So these are genes we all have that are supposed to be there.
Yes, they're physiologically involved in normal growth pathways. But a mutation flips a switch, and the proto-oncogene becomes an active driving oncogene.
The implication of that is pretty profound.
It is. It means we all carry the potential seeds of our own destruction right there in our genome.
That's a powerful anchor. And it's really important for you, the learner, to grasp the mechanical difference here. How do oncogenes cause trouble versus, say, tumor suppressor genes?
This is a crucial distinction. oncogenes cause a problem through a gain-of-function mutation.
So they're the accelerator pedal stuck to the floor.
Exactly. And because of that, you typically only need to mutate one copy of the gene to get that uncontrolled proliferation. It becomes constitutively active.
And tumor suppressor genes are the opposite.
They're the brakes. Their job is to inhibit growth, repair DNA damage, or if the damage is too great, trigger cell death.
Okay.
So to fail, they usually need a loss-of-function mutation. You have to knock out both copies of the gene to completely release the brakes.
Which is Knudson's two-hit hypothesis.
That's the one. And this mechanism is what underlies so many inherited cancer syndromes.
Can you give us a quick example of that contrast in action?
Sure, think of BRCA1 and BRCA2.
The breast cancer genes.
Right. They're tumor suppressor genes. So a person who inherits one faulty copy, that's the first hit, is perfectly healthy.
But every single one of their cells is one step closer to cancer.
Exactly. They're at a hugely increased risk because they only need one spontaneous mutation, the second hit in that remaining good copy, to lose all of that protective function.
Which is why things like prophylactic mastectomy or oophorectomy become a rational choice.
It becomes a necessary preventative measure. We know the genetic defense is already halfway gone.
But it's rarely just one bad gene that causes a full-blown malignancy. You mentioned the accumulation rule.
Yes. Malignant transformation is a multi-step process. It requires the accumulation of several mutations, one after another.
Right.
Vogelstein's work on colorectal cancer is the classic example. He mapped out the sequence APC loss, then KRAS activation, then P53 loss. That happens over decades, often in a specific order, to get to a full malignancy.
It's like a genetic arms race happening inside the body over decades.
It is.
So if the cell has mastered autonomous growth, what's the next hurdle? Long-term survival. First, the endless battery status, obtaining replicative immortality.
Right. So normal cells, according to the Hayflick hypothesis, have a finite lifespan.
About 40 to 60 divisions.
Something like that. Their chromosomes have these protective caps called telomeres, and they get a little bit shorter with every single division.
And once they're too short, the cell just stops dividing and dies off.
Enters senescence and dies, yes.
So what's the cancer cell's elegant but deadly solution?
They reactivate an enzyme called telomerase. Telomerase rebuilds the telomeres after each division, so they never shorten. It keeps the chromosome ends protected and gives the cell line effectively boundless immortality.
Okay, second critical survival trick. Evade apoptosis, the scuttled self-destruct mechanism.
An apoptosis from the Greek for leaf fall is programmed orderly cell suicide.
It's really important to contrast that with necrosis.
It is. Apoptosis is clean. It's internally driven, causes minimal inflammation. The cell breaks into these neat little apoptotic bodies that get cleaned up by macrophages.
Whereas necrosis is just messy, traumatic death from an injury.
Right, like ischemia. It leads to the cell bursting and spilling its contents, causing severe inflammation.
And this is where the most famous tumor suppressor gene of all, P53, comes in.
Absolutely. P53 is often called the guardian of the genome.
So its job is to detect damage.
If the cell detects irreparable DNA damage, P53 is the one that steps in and activates that apoptosis pathway. It says, okay, time to go.
But when P53 itself is mutated, which happens in about half of all human cancers,
that critical checkpoint is just gone. The damaged wrong cells are allowed to survive, to proliferate, to cause trouble. The self-destruct mechanism has been scuttled.
Okay, so once the cell has achieved this sort of molecular immortality, it has to deal with the physical world. It has to grow large enough to matter and then break out to colonize other areas. This is where the physical hallmarks come in.
And the first physical barrier is simply size, which brings us to the fourth hallmark, acquiring angiogenic competence.
Or building a supply line.
Exactly. Let's anchor this to the 1 millimeter restriction. What happens when a tumor hits that size?
It gets stuck.
It gets stuck. A tumor mass just can't grow beyond about 1 millimeter in diameter without a blood supply.
So the cells in the middle become hypoxic.
Starved of oxygen, starved of nutrients, they just enter this dormant, static state. To break out of that and become an aggressive, clinically relevant tumor, it has to secrete pro-angiogenic factors.
Like VEGF.
Like VEGF, yeah. To attract and build new blood vessels. And the supply line isn't just for growth, it's also the highway for metastasis.
The escape route.
It's the escape route.
So once they have their blood supply, they need mobility. The hallmark. Acquire ability to invade.
Right. Normal cells are, they're tightly bound. They respect boundaries, the basement membranes, the extracellular matrix. Cancer cells have to break through.
And they use a three-pronged attack to do it.
They do.
Yeah.
First, just the simple physics of it. Unrestrained growth in a tight space increases the interstitial pressure. It's a constant physical push.
Okay.
Second, they chemically dissolve the barriers. They secrete enzymes, collagenases, proteases that literally digest the matrix.
And third, and maybe the most important part,
they gain true mobility by messing with cell surface molecules called integrins.
which is fascinating because integrins are supposed to anchor cells, but here they become part of the problem.
They do. An abnormal expression of integrins enables what we call outside-in signaling.
And that triggers changes inside the cell.
A whole cascade of changes that increases motility and allows the cancer cell to literally unstick itself from the matrix and start moving. It's like changing the tires on a car from slicks to off-road treads.
And this whole physical transformation is encapsulated in one key concept: epithelial mesenchymal transition, or EMT.
EMT is the critical switch.
So you have epithelial cells, the ones that line organs like the colon or the breast. They're normally static, organized.
Right. They're polarized. They know which way is up. Malignancy forces them to adopt the characteristics of mesenchymal cells.
Like fibroblasts.
Exactly. Mobile, migratory, invasive. Biochemically, they'll lose adhesion molecules like eccogerin and gain motility markers like vimentin.
And this process hijacks pathways from embryonic development.
It does. The same pathways, ROS1-catenin, that are used to move cells around when an embryo is forming are hijacked for malignancy.
So if you could block that EMT pathway, you might not stop the primary tumor from growing, but you could potentially stop it from becoming lethal.
That is a huge focus of targeted research. Preventing that switch from static to migratory is a key therapeutic goal.
Because a tumor that doesn't metastasize is, in most cases, a curable disease.
Far more manageable, yes.
Okay, so now they're mobile, they're in the blood vessels, but they have to stick somewhere else.
Right. The next hallmark, acquire ability to disseminate and implant.
It's not enough just to be floating around. Most circulating tumor cells, or CPCs, they probably just die.
The vast majority do. They need a receptive environment.
Which brings us to Paget's famous
seed and soil hypothesis from 1889.
Incredible.
And it holds up remarkably well. The circulating cancer cells are the seeds, and they have to find a receptive distant tissue, the soil, where they can successfully implant.
So how does that implantation trickery actually work?
It's a brilliant subversion of the body's own systems.
Oh.
The cancer cells start expressing inflammatory cytokines. These cytokines trick the endothelium, the lining of the blood vessels, at that distant site.
They trick it into thinking there's an injury there.
Precisely. The endothelium becomes activated, and it starts expressing receptors like selectins.
Which then grab onto the circulating cancer cell?
They bind to the integrins and selectins on the cancer cell's surface, and that allows the cell to cross the vascular barrier and colonize the tissue. They literally turn the body's repair systems into their own personal welcoming committee.
Unbelievable. Next up, the ultimate cloaking device: immune evasion. The foundational idea from Ehrlich, Burnett, and Thomas is that our immune system should recognize cancer as not self and just eliminate it.
And it probably does. Countless times for microscopic cancers we never even know we have.
But clinical cancers, the ones that matter, they obviously escape. How?
Two main ways. They can suppress the expression of their tumor antigens, which basically makes them invisible to T cells.
They put on an invisibility cloak.
Or, and this is critical, they actively co-opt the immune system's own regulatory processes, specifically the T cell checkpoints.
And that co-opting is the absolute cornerstone of modern revolutionary cancer therapy.
It is. The clinical anchor here is the development of T cell checkpoint inhibitors.
So these are drugs targeting pathways like CTLA-4 or PD-1.
Yes. And what they do is, effectively, they take the brakes off the immune system. They block the natural off switches that tumors exploit to shut down the T cell response.
And by blocking the brakes, you reactivate the T cells to go and kill the cancer.
And it has been utterly transformative for diseases that were previously untreatable, like metastatic melanoma or renal cancer.
Okay, the final hallmark we need to cover is about fuel, change in energy metabolism. This is the Warburg effect.
Right, and this brings us back to the reality of that tumor microenvironment. It often has sporadic blood flow, which means low oxygen states or hypoxia.
And the paradox that Otto Warburg described is called aerobic glycolysis.
Yes. The cancer cell breaks down glucose into lactate, instead of shunting it into the much more efficient, oxygen-dependent mitochondrial cycle.
Even when oxygen is available.
Even when oxygen is available, that's the paradox.
But why would a cell choose the inefficient route? That seems counterintuitive.
Because the priority isn't energy efficiency, it's speed and building blocks.
Yeah.
Glycolysis is much, much faster than mitochondrial respiration. And more importantly, the process produces all these necessary intermediate molecules, the precursors for lipids, nucleic acids, amino acids.
The literal building blocks you need to build a whole new cell.
Exactly. For a cell line that is constantly duplicating itself, it's prioritizing rapid construction over maximum energy yield.
And this leads to a sort of cooperative state within the tumor, metabolic symbiosis.
It does. The lactate that's produced by these glycolytic cells isn't just waste, it's fuel.
For other cells in the tumor.
Exactly. These lactate-producing cells supply lactate to adjacent cancer cells, which can then take up that lactate and use it very efficiently in their own citric acid cycle. It's this dynamic, collaborative environment that helps the whole tumor thrive. #tag tumor growth dynamics.
Understanding how cancer grows is so important for prognosis, and the math here is genuinely startling. If a cancer starts from just one cell, the progression is described by 2 to the power of n.
And that math really illustrates the silent phase of the disease. It takes roughly 30 generations, or 30 doubling times, to reach the point of clinical detectability.
Which is about a 10-millimeter mass. A billion cells.
About a billion cells, yeah. But the astonishing part is that from that point of detection, it takes fewer than 15 more generations to reach a fatal, life-threatening mass.
So the vast, vast majority of the cancer's physical history is microscopic and invisible.
And harmless.
And harmless. The part the patient actually experiences, the clinically detectable growth, is almost entirely the final sprint.
It is, and this is why we observe what's called Gompertzian growth.
That classic S-shaped curve.
Right. Early on, the growth is exponential, it's incredibly rapid, but it starts to slow down as the tumor gets larger.
Why does it slow down?
For all the reasons we've talked about. Competition for nutrients, poor oxygenation in the center, problems with waste removal. The physical bulk just makes it harder to keep proliferating at that exponential rate.
Let's use a clinical scenario here, because this math really reframes the patient's experience.
Good idea.
Okay, so imagine a 60-year-old patient. They noticed a lump about a month ago. It's diagnosed as a 1-centimeter mass. The patient is, understandably, confused and distressed. They're asking, why does this seem so sudden? I felt completely fine a few weeks ago. How do you explain that? How does the clinical presentation mask the true decades-long history?
That confusion is so common, and it's rooted right in the math of that Gompertzian curve. That 1-centimeter mass took 30 doubling times to form, the 1 month that they noticed the lump. That probably represents only the final 2 or 3 doublings, where the increase in volume is suddenly massive.
So the first 99.9% of the tumor's volume growth happened silently.
Over potentially decades, yes. They only became aware of it when that rapid acceleration phase at the very end of the curve began, when it finally became big enough to feel or to press on something.
So the apparent suddenness is really an illusion created by the math.
It is, and it reframes everything. Diagnosis isn't the beginning of the cancer, it's just the moment we finally see the cumulative effect of a very long process. If you're revising this, spend time on that 2 to the math and the shape of that curve.
Okay, moving from the microscopic mechanisms to what actually starts these failures, the book rightly stresses this interplay between nature versus nurture.
And that balance is so crucial, and it's completely context-specific. It is never just one or the other.
Right.
You have to assess which is the dominant factor for any given cancer. Lung cancer, for instance, is overwhelmingly driven by environment. Tobacco. About 80% of cases, it's largely preventable. But then you look at cancers linked to a highly penetrant germline mutation, like BRCA-associated breast cancer.
And there, the inherited risk is the dominant factor.
It absolutely is. And knowing that balance dictates the intervention, is it a public health campaign about smoking, or is it radical prophylactic surgery?
So let's summarize some of those key inherited syndromes from Table 12.1 in the book and their management.
The classic anchors are in the GI tract and breast cancer. So first, familial adenomatous polyposis, or FAP.
Linked to the APC gene.
Right, and it's highly dominant. The risk of colorectal cancer approaches 100% by the time you're 40.
100%.
So because that risk is so high, the prevention has to be radical. Prophylactic pen proctocolectomy, often done in early adulthood.
Then you have Lynch syndrome or HNPCC?
Lynch involves mutations in DNA mismatch repair genes. It dramatically increases the lifetime risk of colorectal, endometrial, and ovarian cancer.
But the intervention is different.
It is. Because it's less dominant than FAP, the strategy shifts from prophylactic removal to intensive surveillance.
So frequent aggressive colonoscopies.
Exactly. And for inherited breast cancer, BRCA1 and 2.
Knowing that status dictates a completely personalized high-risk screening protocol.
And because the risk is so high, particularly for ovarian cancer, which is so lethal, prophylactic mastectomy or oophorectomy are offered as risk-reducing strategies.
The takeaway is clear. The specific gene defect dictates the specific and often drastic preventative measure.
And on the nurture side, the environmental causes from Table 12.2. It's all the preventable risks: tobacco, alcohol, UV exposure, certain viral infections,
HPV and Hep B.
and lifestyle factors like obesity. These are the labors for public health. Hashtag tag the management framework.
The book stresses that modern management has to be comprehensive. It spans the entire timeline of the disease.
Right, and it operates across two axes. There's the axis of scale, from an individual changing their diet all the way up to the WHO setting global policy.
And the axis of disease development.
From prevention all the way through to palliation. And this is a huge philosophical shift. Management doesn't end when active treatment stops.
And because it's so complex, no single clinician can master all of it.
Impossible. Molecular biology, surgery, radiotherapy, chemo, palliative care. It necessitates the multidisciplinary team, the MDT.
The MDT. It's meant to guarantee that every patient gets appropriate, evidence-based management. What are the three fundamental questions every MDT has to answer?
These are the pillars of the recommendation. First, diagnosis, stage, and molecular profile. What's the histology? How far has it spread? And what are its genetic vulnerabilities?
So BRAF status, PDL1 status, things like that.
Exactly. Second, goal of treatment. Are we aiming for a cure or life prolongation, treating it like a chronic disease? Or is it purely for palliation of symptoms?
And third,
treatment options. What combination of surgery, radiation, systemic drugs will best achieve that goal with the fewest side effects for this specific patient?
Now, the MDT sounds ideal, but the source gives some crucial caveats in Table 12.4. I mean, I've sat in enough MDT meetings to know they aren't always perfect. The book notes the risk of it becoming a rubber stamping exercise. How does that happen? And why does the clinician still hold the final responsibility?
That's a fundamental point. An MDT can become a rubber stamp when it just rigidly applies general guidelines without considering the individual. Right.
It's also incredibly time-consuming, so there's pressure to be efficient, sometimes over being nuanced. And crucially, the patient isn't in the room.
That's the key.
The MDT makes a recommendation based on scans and pathology, but the individual clinician has to go and assess the patient's fitness, their other illnesses, their social support, and most importantly, their own wishes and values.
So the recommended treatment might be anatomically perfect, but if the patient has severe heart disease or just doesn't want it,
the toxicity might be completely unacceptable. The clinician's job is to translate that recommendation into a shared decision with the patient. The MDT provides a starting point, not the final word.
Okay, moving to detection. The first line of defense is screening. Finding cancer early in asymptomatic people to improve outcomes.
But screening programs are really complex public health interventions. They need strict justification.
And they have to adhere to the Wilson-Younger criteria. Right. These criteria cover 3 domains. The disease itself has to have a recognizable, treatable early stage. The test has to be sensitive, specific, acceptable, cheap, and safe.
And the program has to actually have high-quality treatment facilities available.
Screening for things you can't treat is unethical.
Now, the concept seems simple. Catch it early, you live longer. But this brings us to one of the most important concepts for any medical learner: the screening biases. Why can just looking at survival rates be so misleading?
This is a vital anchor, because these biases can make a useless or even harmful screening program look like a huge success.
So let's break down the 3 main biases. Start with lead time bias.
Lead time bias is, it's essentially moving the start line without moving the finish line.
Okay.
If you detect a cancer earlier through screening, let's call that point A, than you would have through symptoms. Point B, the patient appears to live longer if you measure survival from the date of diagnosis.
From A to death.
Right. But if the screening didn't actually change the biology or the date of death, that perceived survival gain is just an illusion. It's just the lead time you gained by finding it early.
So the only thing that matters is a reduction in the population's mortality rate.
That's the only true measure of success.
Okay, next, Selection bias.
This one is more straightforward. The people who choose to participate in screening are fundamentally different from those who don't.
They tend to be healthier, more health conscious.
Exactly. Healthier, more educated, more likely to seek treatment. So the screened group is already predisposed to live longer, completely independent of the test itself.
So you're not comparing like with like.
Not at all.
And the trickiest one, length bias. I like the analogy of fishing for slow versus fast fish.
That's a perfect way to think about it. Length bias is the fishing net problem.
Okay.
A screening program preferentially catches the biologically slow-growing indolent tumors, the slow fish. They're around for a long time, so the screening net has lots of opportunities to catch them.
Whereas the aggressive, fast-growing tumors,
The fast fish. They might arise and cause symptoms in between the screening rounds. They're harder to catch with the net.
So because the screening process mostly samples the slow-growing cancers, the average screen-detected cancer looks deceptively less aggressive.
And therefore seems to have a better prognosis than the average cancer that presents with symptoms.
So if survival rates are misleading, what is the only way to confirm a screening program really works?
You have to rely on population-based, randomized controlled trials, and they have to measure the gold standard endpoint, the mortality rate from that specific cancer.
Okay, so once a lesion is suspected, you have to confirm it. The book stresses the absolute necessity of pathological or cytological tissue confirmation.
You cannot manage cancer without histology. Tissue is everything. It dictates the classification, the grading, and the molecular profile.
Standard grading is G1 to G3.
Well, moderately and poorly differentiated, but then you have specialized systems for specific sites, like the Gleason system for prostate cancer,
Which grades the two most common patterns?
and sums them up to a score of 6 to 10, with 10 being the most aggressive disease. ##### staging, mapping the extent.
Staging is the next logical step. The purpose is pretty clear. Estimate prognosis and pick the right treatment.
And the global standard is the TNM system.
TN, M tumor, node, metastasis. Let's use the colorectal cancer example from table 12.3 to make this concrete.
Good idea. So T stages define the depth of invasion through the bowel wall. A T1 tumor is just in the submucosa, small, localized.
Potentially removable with just a local excision.
Maybe. But a T4 tumor has invaded adjacent organs. That requires a massive multi-organ resection.
So T is all about local control and surgical complexity. What about N staging?
N staging maps the lymph node involvement, which is a huge prognostic indicator. N1A might mean one regional node is involved, and NBB means 7 or more.
And the difference in survival is substantial.
Huge. And it's what dictates the need for post-operative or adjuvant chemotherapy to mop up microscopic systemic disease.
And M staging is binary.
M0, no distance spread. M1, distance spread. And M1 almost always changes the goal of treatment from cure to life prolongation.
But staging is evolving.
Future is molecular staging. The book highlights using circulating tumor DNA, or ctDNA, in the blood after surgery.
How does that work?
So a patient has their colon cancer successfully removed. If we then find ctDNA still circulating in their blood, it tells us they have microscopic residual disease.
And their risk of relapse is much higher, even if their TNM stage was low.
Substantially higher. And the implication for management is massive. Those patients with detectable ctDNA must get chemotherapy.
And just as importantly, patients who are staged as high risk by TNM but have no detectable ctDNA.
In the future, they might be able to safely avoid toxic chemotherapy because their surgical cure looks definitive. That's personalized medicine in action. ## principles of cancer surgery.
For most solid tumors, surgery is still the definitive local treatment, but it has multiple roles.
Diagnosis, prevention, radical removal, palliation. It's a wide spectrum.
And the philosophy around surgery underwent a huge shift regarding radicality versus metastasis.
A profound and necessary shift. Historically, surgeons followed the Hallstedian principle. You needed radical extirpation to prevent systemic spread.
Which led to ultra-radical procedures.
Yes, but then randomized trials changed everything.
The trials comparing radical versus simple mastectomy, for example.
Right. They showed a clear and, for some, an uncomfortable truth. Meticulous local control is vital, but making the surgery ultra-radical often has very little effect on whether the patient develops distant metastases.
Because the cells capable of spreading have usually already spread by the time of surgery.
Exactly. The problem is systemic, so it demands a systemic treatment.
So the goal shifted to high-quality, meticulous local resection combined with systemic therapy. But surgery for metastases themselves is not always futile.
No. This is the concept of oligometastatic disease, where the spread is limited enough that you can still treat it aggressively with curative intent.
The classic example being liver metastases from colorectal cancer.
Prime example. If you can successfully resect all detectable liver lesions, about a third of those patients can have long-term, durable survival.
And isolated lung metastases, say from renal cell carcinoma.
Also frequently resected successfully. It's a highly selected group, but for them, surgery can still be curative.
Okay, let's shift to systemic and localized non-surgical therapies. Let's just quickly reiterate the 4 main goals of non-surgical treatment to frame this.
Sure. First, curative primary, like for lymphomas. Second, neoadjuvant, which is preoperative treatment to shrink the tumor.
Make surgery easier and more effective.
Right. Third, adjuvant, which is postoperative treatment to kill any microscopic cells left behind.
And fourth, life-prolonging or palliative.
Where the aim is to regulate the disease and extend quality of life, but not necessarily eradicate it. #, systemic therapy and radiotherapy.
Let's start with radiotherapy. It's often misunderstood, but about half of all cancer patients receive it. The mechanism is basically DNA sabotage.
It is DNA sabotage using ionizing radiation. But here is the absolute key mechanism for you to remember. The main effect is indirect.
Okay, what does that mean?
The radiation itself hitting the DNA is less important than the radiation interacting with water molecules inside the cell.
And that creates free radicals.
Highly lethal oxygen-free radicals. And those are what do most of the damage to the DNA.
Which explains the hypoxia note.
Exactly. Since the mechanism relies on oxygen to create those free radicals, hypoxic cells are relatively resistant to radiation.
So simple things, like correcting a patient's anemia before treatment, can actually make the radiotherapy work better.
It can improve oxygenation and improve the effectiveness of the treatment, yes.
And modern radiotherapy planning is incredibly precise.
It's a fusion of anatomical imaging, CT, MRI, and functional imaging, like PET scans.
All to define the target and avoid sensitive organs right next to it.
Right, and this allows for modern techniques like IMRT, which sculpts the dose, IGRT, which adjusts for movement in real time, and SABR,
Stereotactic ablative radiotherapy,
which delivers massive high doses in just a few sessions to small targets, often with surgical level control.
But optimizing these schedules is plagued by the 20-year latency problem.
This is a huge safety and ethical issue. The acute side effects a patient feels immediately, skin burn, inflammation, are often a very unreliable guide to long-term safety.
Because the late effects can take decades to show up.
Secondary cancers, debilitating fibrosis. They can take 20 years or more to manifest, so every time we introduce a new schedule, we're taking a calculated risk. We might see better tumor control in 3 years, but we won't know the full toxicity profile for 20. #, personalized medicine era.
The days of just throwing broad chemotherapy at a cancer are fading. It's all about druggable targets now.
Identified through molecular biology. This is the era of personalized medicine.
Which means molecular analysis of the tumor is now a mandatory diagnostic step.
It has to be. The book gives a powerful example with the drug vemurafenib,
A kinase inhibitor.
which is only effective in melanomas that have the V600E BRAF mutation. If that mutation isn't there, the drug does nothing. You have to test for it first.
So you're targeting the specific vulnerability of that specific tumor in that specific patient.
That's the goal.
And the ultimate personalized approach is immunotherapy, releasing the brakes on the immune system.
Tapping into that hallmark of immune evasion we talked about. By blocking the T-cell checkpoints, CTLA-4 and PD-1, we reactivate the immune system's own ability to kill the tumor.
It's been a game changer.
Completely. Durable responses in metastatic diseases that were previously a death sentence.
But the side effects are a whole different beast compared to chemo.
They are. You're creating this highly effective army to kill the cancer, but that army is also capable of attacking self.
So you get these potentially life-threatening autoimmune side effects.
Or immune-related adverse events, IRAEs. Things like severe colitis, pneumonitis, or hypophysitis inflammation of the pituitary gland causing hormonal failure.
And managing those requires immediate recognition and high-dose steroids.
Absolutely. They are medical emergencies. #, principles of combined treatment.
These treatments are almost always used in combination. The goal is synergy to combat resistance.
Because resistance is the natural endpoint of cancer evolution. By the time of diagnosis, a tumor is not one thing, it's a collection of subclones.
And some of those clones will already be resistant to any single treatment you throw at it.
Right, so if you only use one drug, those resistant clones just take over. Combination therapy tries to overwhelm the tumor on multiple fronts.
Summary box 12.4 in the book gives 4 key principles. The first 3 are about the agents themselves.
1, you have to use individually effective agents. 2, they need distinct modes of action to get synergy. And 3, critically, they must have non-overlapping toxicities.
That third point is so important. You don't combine 2 drugs that both wreck the kidneys.
Exactly. You want to maximize the effect on the tumor while keeping the patient's major organ system safe. If one drug causes bone marrow suppression, you try to pair it with one that causes, say, peripheral neuropathy. You don't compound the risk.
And what's the fourth principle, which comes in when you combine systemic chemo with localized radiotherapy?
That's spatial cooperation.
Okay.
Chemotherapy is systemic, but it might not get into certain sanctuary sites very well, like the central nervous system or the testes. Localized radiotherapy can reach those sites that the systemic drugs can't.
Let's use a clinical scenario to anchor that principle of non-overlapping toxicity.
Okay.
A patient needs combination chemoradiotherapy for anal cancer. It's a curative protocol. So they're getting high-dose radiation to the pelvis alongside systemic chemo like 5-FU and mitomycin. What are the key non-overlapping toxicities the team has to balance?
The key is separating the local from the systemic effects.
Right.
The localized pelvic radiation will cause predictable local toxicity, severe skin irritation in the perianal area, and localized bowel inflammation, which means terrible diarrhea.
And the chemotherapy.
The chemo, especially mitomycin, causes severe systemic bone marrow suppression, myelosuppression. That leads to neutropenia and a high risk of life-threatening sepsis.
So a successful combination means managing the doses so the patient doesn't get severe diarrhea and profound neutropenia at the same time.
Because that would be lethal. The principle is, don't use 2 agents that excessively damage the same organ or system. #tag oncological emergencies.
Before we move on, we have to stress the need for rapid management of oncological emergencies. Time is life.
These are the situations that require immediate life-saving intervention. First, cord compression.
If you even suspect it.
You have to start treatment high-dose steroids, then neurosurgery or radiotherapy when compression is threatened, not when the patient is already paralyzed.
Second, neutropenic sepsis.
Immediate broad-spectrum antibiotics. Aggressive resuscitation. Survival is inversely and dramatically related to the time it takes to start treatment.
And finally, a modern emergency. The immune side effects.
Severe hypophysitis causing adrenal failure or fulminant colitis from checkpoint inhibitors. These are life-threatening endocrine emergencies that need rapid recognition and steroid replacement.
Okay, as treatments get better and people live longer, we have to address life after cancer. And this starts with a crucial distinction between palliative care and end-of-life care.
This is so commonly misunderstood, even by junior clinicians. Palliative care is symptom relief. It should ideally start at the time of diagnosis and can last for years. It applies to any incurable condition, not just cancer.
It's about living well with a chronic disease.
Exactly. Modern oncology increasingly views many cancers as a chronic disease that we regulate rather than eradicate. The goal is long-term growth control.
So patients are dying with cancer, not always of it. And palliative support is key during that chronic phase.
Yes. End-of-life care, on the other hand, is specifically about the last few months of life when curative treatments are no longer viable.
And the focus there is very different.
It's on unique, profound needs. Pain and symptom control, yes, but also spiritual and psychological needs, supporting the family, avoiding the aggressive medicalization of death. The focus is on achieving a good death.
Table 12.7 summarizes the holistic scope. What are some of the common practical palliative interventions we see?
Symptom relief is the cornerstone, so using stereotactic radiosurgery for painful bone or brain metastases.
Placing drains for effusions?
Right, often with pleurodesis to stop them reaccumulating. Using bisphosphonates for dangerous hypercalcemia. And, maybe counterintuitively, encouraging aerobic exercise to combat the debilitating fatigue from cancer and its treatments.
So the overall takeaway here is that the most important factor is early referral.
Absolutely. The transition from curative to palliative modes of care should be seamless, holistic, and it should start long before you've run out of all other options. #outro.
This has been an intensive, high-yield tour through the core principles of oncology, guided by Baily and Love. We've gone from a single rogue enzyme all the way to global management strategies.
So let's just consolidate that essential knowledge for your revision. You must anchor the hallmarks of cancer, the cell's cheat sheet. You need to understand the stark math of the Gompertzian curve and why diagnosis seems so sudden. Be critically aware of the three screening biases: lead time, selection, and length.
And the necessity, but also the potential pitfalls of the MDT.
And finally, know that modern treatment is all about molecular targets. Whether it's a personalized drug like vemurafenib or activating the immune system with checkpoint inhibitors.
That is the perfect roadmap for revision. So, for our final provocative thought to leave you with.
Since these new targeted therapies and immunotherapies are turning previously lethal cancers into chronic regulated diseases, where patients die with cancer, not of it, we face some profound future shifts. What are the long-term societal and ethical implications for resource allocation when we now have to treat millions of people for 10 or 20 years instead of just curing them in 2?
A huge question.
And how must surgical education adapt when the primary goal shifts from radical extirpation to long-term chronic management, where the surgeon is just one part of a perpetual systemic plan? We constantly have to balance the quantity of life we extend against the quality of that life.
That is the future we are all operating in. Thank you for guiding us through this essential deep dive.
My pleasure.
We really encourage you now to open the textbook and use this comprehensive roadmap as your guide. Until next time.